get to. Good morning. I'm calling the Group Healthcare Committee meeting to order at 8:36 a.m. Could you please do the roll call?
SPPA, Rachel Rulinantham. Here. IAFF, Chris Hartwig. Darren Partika. OE, non-supervisory, Leanne Roloffs. Here. We have a quorum.
Thank you. Next on the agenda is item 3.1, public comment. Do we have anyone wishing to make a public comment?
I do not have any comment.
Thank you. Next on the agenda is item 4.1, approval of the agenda for possible action. Can I get a motion to approve the agenda?
Rachel Rulinantham, SPPA, just based on what we're voting on today, I just don't feel comfortable going forward if we don't have a representative from fire. I know it would be a waste of people's time.
For the record, for everyone, we are trying to get a hold of the fire representative. One is willing to call in. So procedurally, would we approve the agenda as is? But
Brian, running to the record, I think we would approve the agenda, and if it comes time to that action item and the members still want to delay it or kick it out for fire to be present, that would be the time to do so.
okay.
Okay.
Right, is that acceptable? Okay.
So Rachel Rulinantham, SPPA, I make a motion to approve the agenda.
Leanne Roloffs, OE3, I second.
All right, we have a motion and a second. If you can do them on the tablets. Any further discussion? And please vote on your tablet.
I don't see the voting part. Just, no, that's no problem. Sometimes I worry it's user error. It let me click the button and I did that part, but then it just disappeared. It just let me again. It let me second it again. I went out and back in.
Now it's up on the screen, so I think we're getting closer.
Is now in the conference.
For the record, Darren Partika has joined from IAFF at 8:40 a.m. And Derek, because you just logged in. We are having some technical difficulties on our tablets. Darren and Derek, I'm getting my names confused. Darren Partika.
Yes.
Yeah. Okay, we're on item 4.1 and waiting for the tablets to catch up for approvals. There we go. We're good. All right, motion passes. Next is item 5.1. We actually have minutes for two different meetings to approve. Item 5.1 is consideration and possible approval of the minutes of the Sparks Group Healthcare Committee meeting for March 19th, 2026. Can I get a motion to approve the minutes from March 19th, 2026? Looks like Rachel was the mover and Leanne was the second. Please vote on your tablets. All right, motion passes. Next item, consideration and possible approval of the minutes for the Sparks Group Healthcare Committee workshop from May 21st, 2026. Can I get a motion to approve the minutes of May 21st, 2026?
Ryan Northington for the record. If I could have the members verbalize the motion, I would be
Yes.
appreciative.
You bet.
Leanne Roloff's OE3, I motion.
Rachel Rulon Anthem, SPPA, I second the motion.
If you could say the, I move to approve.
Oh.
Yeah.
Leanne Roloff's OE3, I move to approve the minutes of the Sparks Group Healthcare Committee workshop for May 21st, 2026.
Thank you.
Rachel Rulon Anthem, SPPA, I second the motion.
Okay. We have a motion by OE, I guess I could do that, and seconded by SPPA. Any further discussion? Seeing none, please vote on your tablets. Motion passes. Next item is 6.1, some announcements from the chair. First of all, Shauna Halterman, HR Director, for the record. Keep forgetting to do that. I forgot that last night, too. Last group healthcare committee meeting, there was a vote to remove the 26 speech therapy session cap and replace it with a 25 session limit with medical review for anything above 25 sessions. That was taken to City Council on June 22nd and approved. The UMR plan document has been revised, so the new speech therapy benefit is effective July 1st, 2026. A copy of that document's posted on the website. Also, at that meeting, that there was a question about whether a new state law would impact the decision on the therapy. And I think, Rachel, you had asked about that, and we said it was autism. It's not autism, it's stuttering, just FYI. But no, it didn't have any relation to that, the state law. That was the only thing I have from the chair.
We had to call for your vote for the minutes.
Oh, okay, thank you. Okay. Procedurally, we're going to back up a little bit to 5.1 and 5.2? Okay. Darren, because you are not present here in the chambers and don't have the tablet, we're going to need a verbal vote. We're going to do a verbal vote for everything now going forward. So item 5.1, consideration and possible approval of the minutes of the Sparks Group Healthcare Committee for March 19th, 2026. Darren Partika, how do you vote?
Darren Partika, IFF, we vote yes.
That was a yes? Okay.
Yeah, we'd like to approve.
Thank you. Item 5.2, consideration and possible approval of the minutes for the Group Healthcare Committee of May 21st, 2026. How do you vote?
Darren Partika, IFF, yes, we would vote to approve.
Okay. All right, I am done with 6.1, so the next is 6.2. Any announcements from members? No. Partika, do you have any announcements?
I do not, other than I apologize for the not being there.
It's all right. Thanks for calling in. All right, next is 6.3. This is the report from the Finance Department on the Group Healthcare Fund. And Wayne, could you please come up? Perfect. Thanks, Julie. I'll take over the screen.
Good morning, members of the Group Healthcare Committee. For the record, Accounting Manager Wayne Weber, Budget Division. The item before you today is the current financials for the fund as of June. And now I must classify this as we're still starting our year-end audit, so there could be some adjustments to these numbers. We'll see as we go forward. Currently, the fund, during the last quarter, we actually saw a little increase in expenditures. You can see that our healthcare claims have reached $10 million, which is a little bit higher than our budget. Overall, we estimated about a 14.4% increase year over year. This year, we're currently at about 16.2%. So we're starting to see some of the increases that Nate's spoke about in some prior meetings. I wanted to get us through June so I could show you some information. I know we've talked about the balances of the fund as we've gone forward, and I have a little history for you. Well, first, is there any questions on the financial statements? Okay, all right. So this slide is a 15-year look at the fund's net assets. The bars are the net asset amount in millions, and this is from 2012. The red line is the months of coverage. So that's if you take the full cost, divide it by 12, that's how much the net assets would cover. As you can see, you can look back to 2014, 2015, 2016 and see where our balance was critically low. And over the past 10 years, we've started to climb out of that hole, as we'll say, and give ourselves a little bit of cushion. Currently, we are at about 8 point, let's see, I'm sorry about that. We are at 10.5 million as of fiscal 26 currently. And our months of coverage is right above 8, right at 8 months. So now I want to take you to a next slide, and this is going to show rate increases over the last 15 years. You can see how it's the same chart with the net assets, and then you can see where we've increased the rates. In fiscal 15 and 16, we had the largest increases of 25%. And that was because the net assets were basically zero. So we needed those net assets, we needed that revenue to create this balance that we're getting. And then over the past 15 years, we've averaged about 4.2% in increase. We've had some 0 years, which we had in 26. And we also had a 0 increase in 22. We had a 0 increase in 2018 and 2017. And in 2014, or 13 and 14, we actually had decreases of 8%. So That's the correlation in that movement that we've increased rates. And with that, I can answer any questions.
Rachel Rulanantham, SPPA. So when you're talking about rate increase, just to be clear, we're talking about premium
Yes,
increases?
premiums.
Okay.
I'm sorry, yes,
That's-
the premiums.
Okay, so let me see if I got this right. 13 and 14, Sparks reduced the premiums
By 8% each year.
each year. And then 15 and 16, they were both 25, so 25 and 25 back to back. Wow, okay, thank you. All right, any other questions for Wayne?
Rachel Rulanantham, SPPA. So just based on this graph, I appreciate seeing it like this because it makes more sense. Are you trying to say like you project that there will be premium increases in the next year, or this is a good level that we're stable, or?
This is just history.
Okay.
I think there's always been a question of, why we would increase rates. And I think if you look at 14, 15, and 16, you can see the necessity for us to increase rates. I mean, our net assets were practically zero. We had no cushion at all. Now, and you have to remember too, net assets, consumption of the plan, use of the plan, and then, members' revenue. So it's a combination of things. For 27, we're not looking at an increase, it's zero. So that's good for the employees, and we'll have to sort of maintain the same kind of spending to stay at this current level we're at.
No, I appreciate this graph. It makes a little bit more sense in my head.
Okay.
So.
Leanne Roloffs, OE3. Do we have the numbers because we're looking at like insurance costs coming out of this account, but also people's premium costs? Do we have the numbers on how many premiums, like retirees, we cover at 100%? That's coming out of this account as well?
Let me go back to the first slide, Leanne. Okay, so, and this is at a high level, and when you start to talk about retirees, it gets a little different because a lot of the retirees have different plans, okay? So the city makes contributions for active employees, right? In fiscal 26, in fiscal 26, the city contributed $11,368,000. Now, the employees, active employees, paid premiums of $1,106,000. So that's our, as employees, contribution to the plan. Now, for the retirees, the retiree subsidies, once again, this is a bundle of a lot of different contracts, so I can't break it out. So the city contribution for certain retirees totaled $325,000. Now, if you come down, you're going to see retiree paid premiums. So this is, some retirees have to pay the full amount. Some retirees pay a portion depending on their contract, once again. So the retiree paid premiums in 2026 were $900,000. So I'm hoping that answers your question.
Yeah, I'm trying to figure out when contracts go into negotiation and stuff like that, and premiums are brought into those conversations, do we also, because like we're not voting on those contracts going through per se for other contracts, who's looking at the health of the fund as if a contract's like, oh, we're going to cover that at 100%, and the city says yes, but the committee doesn't have a say in those premiums?
Are you talking about during labor negotiations?
Yeah.
It's ultimately the city manager who is going to determine if that's something that the city is agreeable to, whatever the proposal is. And then the council after that.
Ultimately,
And-
it's to vote.
Right.
'Cause just thinking out loud, if I go through even department head contracts, typically, we're covering 100% of the premiums for them and their spouse and maybe a fraction of their dependents, or them, their spouse, and their dependents, and that's still also coming out of this account. However, when we get a rate increase, they don't also see that rate increase because we're covering 100% of their premiums. So if we are going to look at a rate increase, I would like to openly, ask department heads or members of council to look at that they too should be considered maybe having a MOU to their contract to also help employees with this account. I'm not sure if we could see those numbers on if they contributed, what the health of the account would look like as well.
I think that's really a deeper discussion to have at another time.
Yeah.
But I see what you're saying, but there's also about 55 people who have 100% coverage because they started here before 2006.
Yeah.
And so there are people under different contracts, under different MOUs, different resolutions that do have different benefits. Some of those benefits are higher because they gave something else up. So each contract stands alone.
Yeah.
Yeah.
Just something to throw out there for
Sure.
consideration.
You bet.
Anything else? All right.
No other questions for Wayne? All right, thank you. Next item is item 6.4. There it is. This is the regular report on the healthcare cost analysis review dated May 2026, presented by LP, and Nate will be presenting.
All right, good morning. Nate Kerr with LP Insurance. For the record, here to go over the group health plan cost analysis report for the city of Sparks through the month of May 2026. Turning to the first exhibit, the active employee claims.
Control L, full screen.
Employee enrollment on line 1 year to date through the first 5 months is down almost 3%, averaging 520 employees per month. Those employees who carry dependents, also known as a dependent unit, is down about 1%, averaging 349. Total number of dependents, i.e. belly buttons for the dependents, is relatively flat, averaging 854. And total membership, total all-in heads, is down about 1%, averaging 1,374. Line 12 is the cost for employee claims. Through the first 5 months is up about 25%, averaging $749. Line 20 for dependent cost is up about 37%, averaging $1,834. When we combine the two for a total all-in active claim cost, line 28, the total composite cost is up about 34%, averaging $1,979 per employee per month. Retirees, single retiree enrollment is relatively flat at 141. Those who carry dependents is flat at 70. The total number of dependents, again, relatively flat at 83. And the total membership also flat at 223 individuals. The retiree-only cost per employee, line 12, is up about 5% over the prior period, averaging $1,354. Line 20, cost for dependents, is down about 4%, averaging $1,200. And combined, line 28, overall retiree paid claims for the first 5 months is up about 2%, averaging $1,949 per member per month, per subscriber per month. This is simply adding in the two for an all-in claims cost. Calling your attention down to line 31, all in 27% above the prior period, averaging $1,918 per employee per month. Total plan cost, this is where we bring in all of the fixed costs, i.e. the cost for administration, stop-loss insurance, et cetera. Combine that with the claims cost to give us an all-in total cost of the plan. Line 31 down at the bottom, far right, so far through the first 5 months is up about 25%, averaging $2,088 per employee per month. I'll call your attention to line 23 just as a notable, that's a good sign there. Total fixed cost is basically flat, which is good. So the cost increases we're seeing, or the higher performance, is purely due to claims performance, not necessarily what we're having to pay all of our vendors and for insurance coverage, which is always good. The IBNR, or incurred but not reported, that's the outstanding liability of the plan through the month of May, is at $1.285 million, roughly makes up 11% of total spend. Questions?
Any questions for Nate? Darren?
No questions.
Thank you. Now we're going to move on to 6.5. Item 6.5 is a report on the City of Sparks pharmacy plan performance for the first quarter of 2026, presented by Vital One. Jennifer is on the phone, I believe.
Good morning. For the record, Jennifer Salas with Vital One. Today we're going to be taking a look at how first quarter of 2026 performed against first quarter of 2025. We're going to take a look at the numbers at a glance and key findings, and then we'll move on to a clinical overview that will be provided by Derek, and Derek is on the phone this morning. If we could proceed on to the executive summary slide. Overall plan per member per month came in at $237.69. This is showing an 11% drop in trend between 2026 and 2025. This trend is primarily being driven by specialty plan per member per month trend decrease of 18% and a traditional plan per member per month trend of 3.9%. Total plan cost for 2026 quarter one came in at $1.1 million compared to the previous quarter's year at $1.3 million for a 15% decrease in trend. Some of our key findings and observations. The GLP-1 script count percent changed by 15.5% with a total of 82 claims in the first quarter of 2026. There are currently 39 utilizers in this class, which is an increase from last year of where it was at 33 utilizers. This is a change of 18.2%. Moving on to traditional and specialty. Traditional trend is driven by diabetes and cardiovascular. Traditional drugs account for 36.1% of overall plan cost and 91% of claims submitted. Specialty trend is driven by hereditary angioedema and chronic inflammatory disease. Our specialty therapies account for 63.9% of overall spend and 1.9% of claims submitted. Moving on to our next slide. As noted earlier, the plan cost per member per month trend is down by 11.8%. This is 16.7% lower than our benchmark. The average plan cost per script came in at $326.33. This is 14% lower than our previous year's reporting, which is $136.61 greater than our benchmark. Specialty accounted for 63.9% of plan costs, and this is 14% greater than our benchmark. Derek will go into some greater details with regards to therapeutic classes and drugs. Moving on, generic dispense rate is holding steady and great at 86%. Our RX count per member per month trend came in at 3%. And our member cost share is showing at 7.9%, which is 10% less than our benchmark. Moving on to plan cost per member per month trend and taking a look at benchmarking, we get a visual. The blue represents our benchmark and orange represents our city of Sparks. As noted earlier, the trend is down by 11%. It's 16.7% lower than our benchmark. And taking a look at specialty versus traditional, here we see that specialty came in at $186.91 in 2025 and at $151.83 for 2026, showing that decrease of 18.8%. For traditional in 2025, we had $82.67 compared to 2026 of the $85.86, coming in at 3.9% difference. Traditional brand versus generic, our brands had a 2% increase between 2025 and 2026, and generic had a 9.6% change. Do we have any questions before I move on?
Any questions? No.
Okay. Average plan cost per script did come in at $326. This is a decrease of 14.4% and is $136.61 greater than our benchmark. Taking a look at specialty versus traditional, specialty did decrease by 17%, and we had pretty much landed flat from a traditional standpoint. Brand versus generic, our brands did show a 5.8 increase between the two periods, and our generics showed a 16.3% increase. Specialty plan cost came in at 62.9% of total plan cost, which is 5% less than 2025 and is showing 14% greater than our benchmark. Between 2025 and 2026, we did have 4 additional claims that came in for specialty. However, it was at 5.8%. I'm sorry. Yes, we had a decrease of 5.8%. I apologize for that. And I'm going to turn it over to Derek now. He's going to give his clinical overview and inspections.
All right, thank you, Jennifer. For the record, Derek Bergquist. Looking at the clinical savings scorecard, we did have a bit of movement here in the first quarter, but diabetes from the traditional side still remains the primary driver. We're relatively steady from a PM perspective. I think that kind of matches with what we had seen in Jennifer's reporting. So you saw about a 3.9% increase in diabetes. And actually, you saw the same, it really matched the 3.9% traditional spend. So definitely a positive here with that relative consistency there. Now, when I talk about the movement, I meant more here with a couple other classes. You know, cardiovascular is now the number 2 after dropping to number 3. Pain and spasm slides in at number 3 after we saw some decrease in the blood modifiers group, which moved them out of the top 3 to number 4. Really, when you think the top 2 through 7 classes, those all kind of revolved around a $20,000 to $35,000 total each. So not much separating those classes, which can kind of lead to that from fluctuation. But, you know, good variety is a positive there from, from a health perspective. You're not having, too many outliers driving the cost because diabetes is going to be your number one for everybody, typically. Now, in regards to specialties, relatively steady from a class perspective, but hereditary angioedema is still the primary cost at about 40% of that specialty spend. So that is, still significant, that one high cost utilizer. Chronic inflamm actually is now back at number 2. Much like I expected, after previously discussing the annual, we saw that cystic fibrosis now flip-flopped back to number 3. Really, we saw those Kalydeco claims that I had kind of talked about in that cystic fibrosis class, which were essentially rebuild claims. So those have kind of fallen off, which really attributes, quite a bit to that specialty drop of 19% quarter over quarter. So that was really, expected. We should, we might like to see what we're kind of expecting from our discussion at the annual. So good to see that kind of come to fruition in data. Otherwise, specialty claims really hasn't moved that much. And in fact, you look at the savings portion next to it, we actually did see some increase in the managed copay solutions as well. That kind of went along with some of that increased chronic inflammatory utilization. So those are really those common drugs. We always talk about Humira forever. Now we kind of saw some biosimilar utilization there, but also just any of those drugs in that class, you're going to have some additional manufacturer dollars available just typically. And so that's why even though we saw maybe total specialty spend decrease, we did see some additional savings thanks to those kind of medications, having some savings out there. Opioid utilization remains steady. However, we did have the care improvement program adding an additional layer of protection there with the pharmacist continually monitoring. So I'm actually excited to see that we did see the care improvement program results come back. So you see the savings there at about $79,000, and that helps with overall health and wellness, which kind of falls in line with what we're seeing for adherence rates. 91 to 94% or so. That's I think I've talked about that before, but just those are phenomenal adherence numbers. But just to give an example of what am I talking about with this care improvement program? I always want to remind us what we're talking about. That's where we're talking outreach to the providers, and we started that in 2025. And so just an example, just give you an example of what we're talking about. So there's an example where basically current diabetes guidelines, we recommend any patient over the age of 40 with diabetes takes one of those statins or that lipid lowering agent. And, so because having diabetes essentially increases your risk of heart disease, you're talking heart attack, stroke. And so what we saw was we identified 9% of the population was not necessarily on appropriate statin care of these members. So after reaching out to the provider, 17% of identified members had statins actually added to their treatment plan and closed that gap. So, this type of program doesn't necessarily stop there. Once we do that, we're essentially going to have ongoing medication monitoring. And that even did show that those members who did start have remained adherent. So it's nice because they're relatively low cost generics when you add it, but you're going to see the medical cost, down the line. So I just wanted to mention that was, something that we saw some really good, savings, and, we're seeing it actually come to fruition, hopefully giving that better cost, or not just cost, but health and wellness savings to the members. And then just last but not least, still some good savings with our Better Choices program, just as a reminder, essentially where we're blocking kind of high cost medications with low clinical value. So still benefiting the plan. Any questions before I move on to the kind of the therapeutic classes slide?
Any questions?
Rachel Rulin Anthem, SPPA. So for our utilization of the Better Choice program and then the care improvement program, is that a fixed cost that we pay to you guys, or does that fluctuate?
So your Better Choices program, that's free of charge. So that's one, that just we try to make sure everybody has that. I think I saw something today that kind of talked about, a new medication came out where they basically had an old triamcinolone generic and threw in some gauze, and they set it at like a couple $1,000s. Like those are kind of like, we just want to make sure that those don't happen. And so there's no cost to the plan on that. But the care improvement program, that cost is, it's a set per member per month. And so it's set at, I think you're contracted about like, I think it's 75 cents or $1 per member per month. If you do that, so it is a set cost, but it does fluctuate based on your eligibility, if that makes sense.
Yes, it does. Thank you.
Any other questions?
No, good question.
There's no more questions.
All right. So let's take a peek here at the summary of the therapeutic classes slide. Kind of gives us just an idea of how we're comparing to the book of business. So looking on the left side, we've seen this before, but diabetes here, that's really where you can see, okay, yep, that is clearly still the driver of cost, but it is slightly below the book of business. So despite being the number one driver, that's still good to see. Now, there was some growth around a variety of disease states. Nothing like too drastic necessarily. I saw the hormonal agents went up a bit, but when I looked at it, it appeared to be more just an increase in utilization, among members. On a positive side, we saw, with some increases, there were decreases, in other classes. So, for example, maybe we saw increase in that class, but then I did see like allergy, asthma, cold went down significantly. And so ultimately, like I kind of mentioned earlier, relatively neutral on the traditional side of things. I think it was about 3.9%. And we'll see that when it kind of goes on the traditional breakout. Specialty is really where, on the right side, that's what contributed to that overall decrease in spend that we saw. There wasn't a ton of movement. However, that movement that did occur was significant. So, chronic inflammatory, that one is still way below the book of business, but we did see some increase in utilization. So, I think when I looked at that increase, though, there were like 2 new utilizers on one specific drug called Dupixent. So we did see that in the top 5. But really, when you compare it to the end of the year at 2025, not a ton of growth there. So I think this was more so the latter half of 2025 where we had seen some increase in utilization. But of course, that does get hopefully offset a little bit with that MCS program, going after those available manufacturer dollars. So just wanted to highlight that. That hereditary angioedema, that's really where you can see, it's just anytime you have a really rare disease state like that, you see it immediately. It's like most clients just don't have that. Another one that I, of course, highlighted earlier, but that's that cystic fibrosis. You can see the big decrease. It's still going to compare, really, it's a lot more than your book of business because you still have the one utilizer on a drug. So it was Kalydeco, but the member kind of switched to Alyftrek. And so with that being still a high cost med, if you have cystic fibrosis, you're going to be on these medications, lifelong. And so, considering the disease is still pretty rare, and compared to the group's, size, you're going to still be higher than the book of business. But just nice to see that, yes, okay, the trend did drop significantly when we removed those Kalydeco claims that had kind of popped in at Q1 of 2025. There was one other orphan drug. That's that Atrovy we'll see on the specialty breakout. That one we had known about in 2025. There was just a little bit of an increase. But that was because there were only 2 fills because that member basically didn't start till February. So when you're looking at it just quarter over quarter, it looks like a bigger increase percentage wise. But I think as we get into the year, a full year on the plan, it won't look as big of a growth. It'll basically be maybe 13 prescriptions versus 12 instead of 3 versus 2. So just, mentioning from a percentage perspective, sometimes it makes it look worse than it really is. But let's take a peek, at the breakout. We just have the next slide is going to be traditional drugs. Mounjaro is still the primary driver. That kind of mirrors that diabetes being the main trend. That is very typical for my other groups, and really across the board we hear about just the increase in utilization of these drugs. But they also do. We've talked about it before. They work really well, and so that's why oftentimes you're switching from other therapies as well. So they've definitely been dominating the diabetes spectrum, those GLP-1s. Ozempic is still there, but, the Mounjaro is starting to dominate even among that class as it does have a little bit better efficacy than the Ozempic. Now, when you talk about the other drugs that kind of pop in here, anytime I'm seeing, other PMPM numbers in the 3 and under, I think that's a good sign. We're only, we're seeing those standard GLP-1s still be there. But otherwise, we're not seeing massive numbers in those spikes. And, hopefully we can, continue to see increased generic utilization in some of these other classes. Now, you do see on this main slide here too that, this is where we see that 3.9% total traditional. It really mirrors that diabetes trend. So it's like when you have that big of a trend, anytime there's movement in that class, it's going to kind of drive your class. But just some ups and downs in those other classes kind of remained relatively net neutral. So that was a positive sign for the plan. And then we take a peek at the specialty on the following slide. And, obviously the number one thing we see right away is that 18.8% decrease PMPM. Obviously that's awesome. I kind of alluded to it. That's because of that Kalydeco kind of falling off in the CF side. Cinryze is going to be your number one. That's that, that's a high cost hereditary angioedema class member that we've been seeing for a long time. Chronic cystic fibrosis, that's the Alyftrek popping in at number 2. Attribute, the orphan drug that I mentioned. So those 3 in particular, those are just really, it's like you get one utilizer on this drug. It's really high cost and it's going to pop up right to the top. So, we've talked about this ad nauseum, but just as a reminder, when you have these kind of rare disease, more rare diseases, it's going to look like a nasty number on the page. Now, Dupixent, on the other hand, that's where it pops in at number 4. This is the first time where we're seeing a chronic inflammatory disease pop in. That has not been, that's not typical. Normally I see that one maybe number 1, Skyrizi popping in there. We didn't actually see the Skyrizi, so that might explain maybe why chronic inflammatory isn't as high as some other groups. But Dupixent has been, commonly growing. It has added new indications, so I'm not surprised by that, in this space. And then, you have an oncology drug pop up, not too atypical either. But ultimately, nice to see, some of that net neutral, movement after the growth from last year. So that's what helped that 19% decrease really appear after we lost those that other Kalydeco. So I'm always happier to see these kind of numbers than kind of the continued increase. But so I just want to just highlight that positive. And so it might kind of become a little more neutral over the course of the year, but definitely a positive from my perspective. Any questions? I know that's always a lot to kind of take in, but any questions?
Any questions for Derek or Jennifer? There are no questions.
No
Thank you.
questions.
Thank you.
Thanks, Tim.
All right, next item is 6.6. Report on the City of Sparks Group Health Plan performance provided by our third-party administrator, UMR. Russ, just give us a minute to pull up your presentation.
Yeah, good morning, everyone. This is Russ Garrett from UMR. Starting on my presentation. Oh, go ahead.
Yeah, give us a second to bring it up.
Oh, okay.
You good? Okay, we're ready.
All right, so this would be total, it kind of follows LP's report. Claims paid through the end of May. Total number of claims that we have processed, taking into account medical, RX, and dental, 21,741. 12,536 was medical, 7,700 in RX, and 1,486 dental. So then we look at really what you pay on each of those. And the total paid, as Nate has alluded to, $4.1 million on the medical side, 400,000 dental, and about 1.9 million in RX. So total paid for the first 5 months, $6.47 million. Good news is that 99.4% of all your claims are going in network, and you're getting a savings amount of about 66.4% on those in-network claims. And then we drop straight down and kind of give you more of like a per member per month total. That drops to a $760 per member per month. But when you look at that compared to our book of business norm, you can see that it is quite a bit higher. And you guys typically have been higher than our norm in that marketplace. Then you slide over to the left a little bit. Number of claims denied, 747, although that number seems high. We've talked about this in the past. Duplicate claims becomes the number one, us being in the secondary position but not getting the primary EOB. That's been an issue. There's little things such as those make up the denied claims. And then we also look at the claims that we've pended so far. So we have 8 claims pending over 30 days, 26 claims between 10 and 29 days, and 259 claims at 10 days or less, right along where we should be as far as our book of business and performance guarantees go. Total number of ER visits so far is 193. You've paid $691,000, which comes out to a per visit claim cost of $3,582 in comparison to our book of business of $2,400. Urgent care claims, you've had 312, paid out almost $32,000. Average paid per visit is 102, real close to what we see in our book of business, actually lower, where we see across the country, $114 per urgent care visit. Before I go to the next page, is there any questions on those numbers, which kind of regurgitate what Nate said?
Any questions for Russ? No questions.
On the next slide, of course, we do, show you guys our performance guarantees, which we've actually hit. You see the targets, what we actually didn't make. So we've hit all of our performance guarantees. And then the calls that we receive within this time frame, we received 1,245 calls, 249 from members, 121 from dependents, and the majority being from a provider, 848. Sometimes we don't get to register the call in one of those 3 categories, so it falls into the all other category, which is 27. My portion is fairly quick unless there's any additional questions. That's all I have.
Any questions for us? And the UMR rep is on site a week from today, on the 16th, if anybody wants to meet with her. All right, thank you, Russ. All right, next item is 7.1. I'll give it a second here to catch up. There we go. Consideration, discussion, and possible approval to recommend to City Council adding additional health plan options for the City of Sparks insurance users, choosing from option A, B, or C as presented. Nate from LP will present, but I may also add additional information as needed.
Nate from LP, for the record, do you want me to go over the presentation
The
again?
shorter PowerPoint, yeah.
Okay.
I think she's got it there.
Okay. I think most everyone was present last couple times we went over this, so I'll try and kind of breeze through it. If you want me to slow down and spend a little bit more time on any particular exhibit, let me know and we can do that. But given that most of this is probably review for most of you, I'll try and keep it moving. Agenda is pretty self-explanatory there. First page, again, is just a high-level summary of, to give a little bit more detail around preventive care according to what's required under the Affordable Care Act. I think the main takeaway from this slide that we just wanted to get across was, regardless of what plan or how many plans is offered at the city, preventive coverage is the same across all plans from a benefit perspective.
What you're seeing here is the original presentation. We had reduced it down to about 7 slides for this presentation, and apparently that's not it. I have it on a thumb drive if you want to use it. Okay. We're going to switch over.
Wanted me to do the whole
It's version 3, if you see that. We condensed it down to just the basics for this, since this has already been fully presented.
Mariah Northington for the record, while we wait for the updated PowerPoint. Rachel, if you still have the same concern you raised earlier, after the presentation would be the time to raise that again. I'm not sure if that's changed since Mr. Partika is present, but I will defer to you on that.
Yeah, because he's present, I have no
Okay.
issues.
Perfect, thank you.
Version 3 is what it's called.
Yeah. There you go. That looks right. I can't see that from here.
Here we go.
Is this like 7 pages?
It says 9, but.
I think that's it. Yeah, because there's a header and yeah, that looks better. Okay.
All right,
Thank you.
back to it. This again, just high-level summary from a benefits perspective of the plans that have been recommended for potential additions to the benefit offering. With the idea being, just as a reminder, we kind of trying to use the city of Reno as somewhat of a benchmark so that we could maybe bring Sparks more in line with the world around us. So with those 3 plans in mind, those 3 plan options in mind, we put together some cost exhibits in different combinations based on different contribution approaches. So the first offering is offering A. This option is assuming that we utilize basically the same cost as what the city is paying all in today and just set it at a fixed cost for each tier level. We arbitrarily, not necessarily whole arbitrarily, but arbitrarily set those numbers based on the total dollar cost broken out by each individual tier, which is where we came up with the 1,100, 1,800, 1,700, 2,400 numbers. Bottom line is it under that type of a structure, which again is a fixed dollar contribution model. You guys are used to a percentage-based. City of Sparks has been on a very traditional percentage-based contribution structure where you pay 100% of employee and a percent of dependents, depending upon what has been agreed to. So this would be a change or a shift away from that traditional structure from a percentage-based to a fixed dollar or defined contribution, as we sometimes call it. So you can see how the numbers play out. Obviously, as you go farther to the right in these plan designs, the cost, the overall cost or the total cost column goes down, which makes the employer contribution at that set dollar amount obviously more favorable to the employee as you get down the cost spectrum. And then we just took that and broke it out just for visual for folks of what that looks like on a purely an employee cost. What's it going to cost me, the employee? And point of clarification, just as a reminder, the only difference between current plan and new current plan is the contribution structure would change. The benefits are identical, the current plan and the new current plan. Offering B is the next contribution structure of consideration. This basically says we're going to maintain the current plan at the current cost structure just as it is today. So we're not changing anything. And we're going to make that the quote unquote base plan or the starting point, if you will, for everyone. In addition to that, we're then going to add those other two options, but we're going to pay the exact same. I say we, the city would pay the same exact amount for each of those plans based on the base plan. With the idea here being that if you like what you have today or you're okay with the cost that you're paying today, you have an option to stay as is, no changes. However, this does introduce choice into the equation for these other two plans in not only benefit structure based on what type of needs you may have as an individual, but also from a cost perspective. I think we talk about retirees quite a bit, have to pay quite a heavy amount of the contributions. this will at least provide some options where there are lower cost options available. And then again, the breakout down at the bottom, just on an employee cost. What will it cost an employee? Questions?
Any questions so far? No questions.
Okay, the last one, offering C. Same concept as the prior slide, offering B, same concept here, only the quote-unquote base plan. We are moving from the current plan to option 1. So option 1 will be the starting point, if you will, for what the city would pay for. And those numbers under ER cost, which stands for employer cost or city cost, are based on the same contribution structure that you have today. 100% per employee, 75% per dependent. So that's how those numbers were created. And we then, as the base plan, utilize those numbers and carry them both to the right, which is for a buy down option or a lower cost option, and or we allow for folks to buy up, pay the difference between this new option 1 plan and the current plan, which would be then the buy up plan. So same concept where we're picking one plan as a starting point and then offering options around it. This one is we have one lower cost option and one higher cost option. This again is just the rate exhibit for the retirees with Medicare. Obviously, retirees with Medicare receive a slight subsidy because they have Medicare. They're paying for Medicare. They have to pay for Medicare B. And so the city provides a credit for that premium amount, understanding that for those types of individuals, Medicare is primary and Sparks is secondary. So it only makes sense that the rates would be slightly less. Claim scenarios, I won't go super into depth on all these. We've already reviewed these, but again, this was an attempt to at least give folks a better feel for how things might play out for each of the 3 plan offerings. And the 4 scenarios here we attempted to demonstrate on a hypothetical is from relatively mild or very low cost, that's scenario 1 being preventive care, all the way up to a much higher cost, higher severity type claim situation, that being an inpatient hospitalization. And then obviously each of the bullet points under each of those scenarios let you know which plan and what that would look like from an employee out of pocket. What would this cost me, an employee? Any questions?
Any questions for Nate? No? Any questions for me that Nate didn't answer?
Shauna, Darren Partika, IFF, just a quick question since I can't see the slides.
Are you logged in on a computer too?
No, I'm not. I'm just on a cell phone out in the mountains.
phone?
So kind of
Okay.
limited of what I could see. I just want to confirm that option B was the one we discussed at the previous meeting. It was like our current plan, the PPO 400, and then the high deductible 2600.
Correct, yeah. So
Okay, and all those
the current
slides,
plan would be
everything else just remained the
unchanged.
same.
I'm sorry, could you repeat that?
And all the numbers from the last kind of presentation stay the same on that option, is my understanding?
These are the exact same slides. Nothing has changed.
Okay, perfect.
Yeah.
Cool. I'm familiar with those slides. I just want to make sure I didn't miss anything from the last meeting to this one was all before we move
Yeah,
on.
We just condensed the presentation and removed some of the slides, but otherwise they're the same.
Perfect. Thank you. Yep, I understood the presentation. Just want to make sure I was on the same page. Thanks, Nate and Shauna.
Thank you. All right, so at this time, you probably have to switch it back. There you go. I am seeking a motion to approve and recommend to City Council the adoption of either plan offering A, B, or C. And my understanding is if there isn't a motion, then it just dies, correct? Right, yeah. Is there a motion for any of these plan offerings?
Leanne Roloff's OE3, I move to approve and recommend to City Council the addition of plan offering B as a health plan option for the City of Sparks insurance users.
All right, we have a motion. Do we have a second?
Darren Partee, AFF, I second that motion.
All right, I have a motion and a second. Any further discussion? Seeing none, we're going to vote verbally. So we need everybody to vote yea or nay.
Yes.
Yes.
Nay.
Nay. Okay, so we have 2 yes and 1 no. I'm waiting for you to put these on the system. Is it up there? Yeah.
Leanne Roloff's OE3, are we able to ask Rachel what your group wanted or the justification during this time?
So Rachel Ruland-Anthem, SPPA, we did a vote, and the majority of the members had said no change. Tried to get some clarification on what their concerns were. Some of the concerns were, which Shauna had, I'd emailed Shauna about, was how this would impact medical on retirement. Some concerns were brought up because there's a lot of talk about consolidation with Washoe County. And then what's considered the cherry picking clause, so picking the best whatever from the different agencies, and we're the best healthcare in the valley. That was another concern that was brought up. I think there was something else, but that's the only ones that stand out. But it was pretty, we had the majority, I think it was about 51% voted for no change. And then it was like, I can look up I have it right here. 51% voted no change, 36% voted option B, 11% voted option A, 2% voted option C.
Thank you. I appreciate that. Just to note, plan offering B, which now that we do have 2 votes, does pass. The next step would go to City Council. We plan to take it on July 27th for their approval. But all employees would be able to remain on the current plan with no change. So if that was a concern, it's okay. They'll still have that.
I'd emailed you before about that too, and so.
Yeah, if that 51% doesn't want to change, they don't have to. That's fine. But there will be choice for those who do have other situations where their healthcare could be different. So it also in regards to that, I've spoken to both our LP reps and our UMR reps. We'll have some in-depth, detailed sessions, some one-on-ones in October, November, before and during open enrollment to help people decide which choice would work for them. And they do have the option to change every year. Okay. No other.
Excuse me, Shauna. This is Russ from UMR. It was a little bit hard to understand. Was that motion for option B or C?
B as in boy.
Okay, thank you.
Like Bravo. Yep. Yes. So option B, which retains the current plan and adds the option 1 and option 2 to it with the same 75-25 structure. All right, so that motion passed, a 2-1. Moving on to the next item. Request for future agenda items. Are there any requests for future agenda items? Hearing none, move on to item number 9, announcements from staff and committee members. My only announcement, as I mentioned, the UMR rep is on site next week. And that we will take this to council on the 27th, and if it's approved, it will be plan offering B. It will be effective in January, and we'll have those changes during open enrollment. Any comments from committee members?
Leanne Roloffs, OE3. I just wanted to thank everybody for putting together the presentations, answering our questions, and then also still holding the sessions in October, November. I also just want to ask members who are more worried about what option they're picking to actually utilize those resources. I think the most frustrating thing is getting a ton of emails about questions and then people don't actually attend the sessions that are being brought forth. So I highly urge everybody to go to them. And if there isn't one that works with your schedule, email us and let us know so that we can maybe find another date that works for people as well. But overall, thank you very much for all your guys' work into this too.
Yeah, you're welcome. We do want to educate people as much as possible. I know for a lot, it's a lot of new information, and we want to make sure that we get that out as much as possible. I held 11 of those sessions with different departments, different locations via Teams to try to explain the differences, and we'll have a lot more. Yep.
And I agree with Leanne, and a lot of my members reached out and said how receptive you were within the day. And then if you didn't know from our meetings, from those sessions, if you didn't know, you got back to us very quickly. So we're all very appreciative.
Good. Yep. Glad we got it done. Darren, do you have any comments?
No, yes, much for commenting.
Cutting out, yeah. Could you hear what he said? Yeah, me either. The phone kind of cut in and out,
Can you hear me now?
sort of.
No, the rest of the people can afford. Oh, yeah. The boathouse is fine.
Are you guys able to hear it all?
Yeah, no, we can hear you.
Okay, perfect. No questions on my end. Thank you guys for all the information leading to the vote, and I appreciate you guys for accommodating me on my phone up in the mountains today.
Thanks for joining us. We appreciate it.
Of course.
Okay, any comments from the public? Do we have any public comments here? Okay, we don't have any public comments. That leads us to an adjournment. There being no more further business, the meeting is adjourned at 9:48.
Russ Garrett from UMR.